So our next speaker is Dr. Tom Odorizio, and he's a professor of medicine and director of the neuroendocrine tumor program at the University of Iowa, and he's a medical advisor to NCAN. So welcome, Dr. Odorizio.
I just want to check, did Marianne hand out the sheet? No, there's people, it looks like we have them here too. Okay, that's an empowering sheet. Everybody's got them. Good, that's a must. I want to thank Marianne and Bob for allowing me to share some thoughts with you, and I very much appreciate it. I also, I don't know if Dr. Inetti is here, or if he left. I wanted to apologize for chewing up his name. There's a thoracic surgeon, Iannatoni, at our place, and so when I was addressing Dr. Inetti, that flashed in front of me, and I put way too many vowels in his name, as most people do with mine. But I really, again, appreciate this. It's great to be in an audience that recognizes endocrine oncologists. And so the little story goes 15 years ago when I was we came to Iowa, I was able to get my clinics in the Holden Comprehensive Cancer Center, which is managed completely by a medical oncologist. And I got in and I started working, and after about a month or two, I was coming to the hospital, and one of the medical oncologists parked next to me, and I got out of my car, he got out of his car, and I introduced myself, and he said, "Oh yes, you're an endo-oncologist, aren't you? Not a medical oncologist." And I put my head down, I said, "Yes, I'm an endocrine oncologist." He said, "We consider endocrine oncologists as overrated, overpaid country docs." And I said, And I looked and I smiled, and then I looked at my 2004 Hyundai and his 2005 Jaguar, and I said, "You're right, I'm overrated." You know, that's all I could say. It was numbing. However, you learn to adjust to it, so it all turned out great. What I want to share today, and you know, the Latin expression is repetitio est mater studendum. So repetition is the mother of learning. I tell the tale by embellishing a little bit of history of some of the many people that really helped forge neuroendocrinology and the therapies that we see today, and then show you the problem, which you've already seen and know personally, and then talk to our program at the university, which is a multidiscipline neuroendocrine tumor program. And that sheet we've put together over about 12 years. And there's a lot of information on that sheet, but I think you'll see that it can empower you as you go forward in the co-decisions of your management. And I'm supposed to be doing PRRT. Everything is fair game on the questions for PRRT. We attended the third World Congress a week and a half ago and heard just about every country outside of the United States talk about PRRT, including Australia and India. And we're coming fast into it here. We have, as you know, Excel Diagnostics is a business, and Abe Delpasan is excellent. There's mechanical issues in trying to get in and payments and that sort of thing, but he does an excellent job. And we'll have the first Y90 therapy within 2 weeks at the university. So we're very happy about finally getting PRRT here, as well as the study that was alluded to. So without further ado, if you look at the evolution in just a few slides of neuroendocrinology, the medical therapy, it all began back there in 1902 when these two brother-in-laws got together as physiologists and identified a substance in the blood of a dog after they extracted the stuff from the stomach or from the intestine, and they found that when they put it back into another dog, it caused a lot of bicarbonate loss. And they coined the term secretin, and the word hormone was invented at the same time. That's a military word in Greek, which means I arouse or I stimulate to activity. And that began really endocrinology as we know it even to the present time. And then Edkins was another physiologist in 1905 where he identified a substance from the dog's stomach that caused acid to be released. And you've heard about gastrin. And in fact, that was the first functional neuroendocrine tumor of the pancreas, was a gastrin-secreting tumor, as I'll show you in a minute, by two clinicians. But it wasn't until 1961 that they knew that the substance was gastrin. He was a physiologist and didn't know that he coined the term, but didn't know what the structure was. And then Obendorfer, you heard about him in 1907. He's a pathologist that saw these cells in the intestinal tract, and he saw that they looked like a carcinoma, but they were normal, but they were moving through the bowel wall. And he coined the term that stayed with us for 100 years, carcinoida, which is carcinoma-like. And he was really the if you will, the namer of these neuroendocrine tumors. And as we learned, all neuroendocrine tumors were classified as carcinoid. Now they're considered one of the tumors of the neuroendocrine system. Then insulin was isolated in 1921 and stabilized. That got a Nobel Prize for Banting and Best. And then in 1931, a man named Saul Hirsch, who was an internist that worked at Mass General, had decided that he would give I-131 internally. That was the first use of radioactive material internally. He had patients with first with overactive thyroid and then with thyroid cancer. He determined that iodine predilects to the thyroid and used the I-131 for his 30 patients with thyroid cancer. He was called away to World War II, and his two colleagues that he trusted very much published his work without his name. And it happened that I mentioned this at the American Association of Clinical Endocrinologists meeting, and the daughter of Saul Hirsch came up and introduced herself. And it was a very powerful story that she told, because when he came back, then he got his patients back and published on his own his own series. But he was the first to use I-131. And it happened that when I was looking that up, I found his paper, and to this moment I'm ecstatic that I did, because of the story that I learned. And then I'll show you a picture of a true neuroendocrine cell. But Friedrich Ferreter, an Austrian pathologist, noticed these cells in the intestinal tract, and as a pathologist, he said something in pure German, something like "Mein Gott, das ist ein Helizellen." This is a clear cell, and he named these clear cells the endocrine cell that was giving rise to the hormones that the physiologists were describing. So he was the first to talk about the neuroendocrine cell itself and identify this pattern that I'll show you in a moment. And then in 1955, Robert Zollinger and Ed Ellison described two cases of fulminant gastric ulcers duodenal ulcers that Dr. Metz told you about, what happens when you have excess gastrin. They operated two patients, and in their pancreas were two tumors, and the tumors were found to be making gastrin. And that was the first description of the neuroendocrine tumors of the pancreas. So we have the carcinoid described back in 1859, but coined the carcinoid tumor of the bowel, and then the pancreatic neuroendocrine tumors were clinically introduced by Zollinger and Ellison. One of the patients was a 17-year-old person who was part of a multiple endocrine neoplasia 1 family that Dr. Metz mentioned. And she went on to live until she was 68. I was privileged to take care of her from 1972 until we left Ohio State in 1999. And she didn't pass of her gastrinoma because Dr. Zollinger took the target out. He took the stomach out of these patients, because the target organ was the stomach and the acid. And so this, the patient I took care of had very high gastrin levels until her death, and she also had very high levels of somatostatin in her blood. So the somatostatin was actually competing and controlling the gastrin levels in her. She died of a clot in her legs, but worked until she was 68. So that was the first neuroendocrine tumor introduction for the pancreas. And then we had the membranes identifying the receptors in 1961. And then something really started to happen when somatostatin was discovered in the brain by Brazeau and Shalley in 1973. And within 3 weeks of the publication of the somatostatin peptide in our bodies, Sandoz, now Novartis, sent a memo to their biochemist and their medicinal chemist, and they said, we must make a compound that looks like somatostatin because it's an important, very important hormone. And in 1980, then, octreotide was introduced. It's a synthetic peptide that we all know as sandostatin. And about 5 years later, lanreotide then came. David Coy made that from Tulane University, and then it went to Biomeasure and then Ipsen. So that's the team, and the person in the yellow sweater is Janos Plesch. He managed 50 medicinal chemists to make the compound I'll show you in a moment is octreotide, but it took them 7 years from the time that somatostatin was identified and characterized before they were able to come up with a synthetic look-alike. And they did not know if it actually matched the action of somatostatin until probably 4 or 5 years after the peptide was released. And then there was the octreoscan. Eric Krenning from Rotterdam took the octreotide. He put a linker on it. They added indium-111 because he was a nuclear medicine person, and lo and behold, you have pentatreotide, which we all know and use as octreoscan. We were the last in the United States to get that test. It came out June 8th in 1994. So we were very late in getting the octreoscan in the United States. And then the idea of the octreoscan and putting a radioactive material on it and having it go to these tumors was exploited by Richard Baum, and he came up with the term theranostics that we now are able to show, wherein he took the identical form of octreotide. There was a cage on it that they put gallium in, and he really was the introducer of the gallium-68 because he was aware of it. He's a nuclear medicine physician at Bad Berka, Germany. Some of you may have been there or know him, but he's the one that then took the concept of the exact same key fitting into the locks that we heard about today on neuroendocrine tumors, and then taking the gallium out of the cage and putting yttrium or lutetium in it. And that's PRRT. We'll go over that a little bit deeper, but the combination of the very same key for diagnosis and for therapy is called theranostics, and that's what the congresses have been for the last 3 years on theranostics. You saw this slide, neuroendocrine tumor incidence, that is how many new cases per year, has risen 500%. And the line on the top is all the other cancers. So you can see that it has risen. Again, they say it may be earlier detection, there may be other issues, but it's not just our country, it's several countries. They reported 4 other countries reported their registries at the ENETS meeting in Europe 2 weeks ago, and it's identical rise in incidence. There seems to be a higher rise in new tumors in women over men from the other European countries. This is a paper from the South America, but they talk about the differences in what predicts survival. When you look at these lines dropping off the table, you have to remember that's a stand away looking at a forest. It doesn't talk at all about the interventions that go on in your daily lives, in my daily life, in terms of intervening with the therapies, changing the course of the tumor. These are big views from an epidemiologic look. And clearly, as we learned earlier, stage is important. The stage of it. Is it regional? Is it local? Is it distant? In terms of how you look at the cumulative survivals. So the local ones do very well. I think that's it should be blue. I think there's just a wee bit of a color problem. But the red line represents the distant metastasis at the time of surgery. And that is an overview. That has nothing to do with years of intervention. So you have to look at this in a way that it's meant to be looked at, that predicts when you have it local, it's a tumor. When it's regional, it becomes a cancer. When it's distant, it's away from its source. And the other thing that makes a difference is the grade. We heard about the Ki-67. We'll hear another word or two about that. But the Ki-67 is still a very, very important proliferation marker. Our cells are programmed with a certain speed of growth, and these tumors have the same thing, and there's a chromosome that regulates it, and we'll talk to it. But again, it's not a real surprise when it's very well differentiated and it has a Ki-67 less than 20. You can see the green line is well differentiated. As you get poorly differentiated, the grade 3s, the survival falls off. As well, that's the Ki-67, and again says the same thing. When the Ki-67 is less than 2%, it's grade 1. When it's 3 to 20%, it's grade 2, and greater than greater than 20% is a grade 3. And that's a big look at how these tumors perform watching them, the natural course, if you will. So put that in perspective. Now, let me say a couple of words, and we show that these slides have been prepared for the World Congress a week ago and for Emory University and a few new ones. But the nature of the neuroendocrine cell is something you keep that defines their nature, defines their differences between, epithelial cells, lung cells. These are a very specific system of cells in our body. Normal cells in our body, by the way. So they can take up precursors like tryptophan and they can make serotonin. We've heard that. They can store neuropeptides and release their own peptide that they're supposed to release and other peptides. We heard a little bit about staining. We had a person from Washington, from Portland, Oregon, that had a tumor that had 5 different peptides in the tumor. But the patient was functioning as an insulinoma, making too much insulin and having hypoglycemia, and was named an insulinoma, but had 5 other peptides in the tumor itself that did not manifest clinically. They can express receptors, as we know, and the predominant receptor that we're most targeting now is the receptor subtype 2. There's a 1, 2, 3, 4, and 5 subtype somatostatin, but the 2 is very, very important normally on these cells and all cells in our body, but particularly replete on these tumors, and that's why we can advantage them. They can express peptides, like I told you. They can make more than one kind of neuropeptide, and they can become tumorigenic, as we know. That is a neuroblastoma cell. You can see the clear area around the nucleus, and those little X's that I put in there, I muted it. That's a receptor subtype 2. This was given as a gift from the late pathologist, Dr. Quellman at Children's Hospital, but it absolutely shows the nature of the cell very, very well. You can see the very clear area around the nucleus, and this stain was a neuron-specific enolase, and that is how these cells look in a smaller dimension in every tumor of the body that is a neuroendocrine tumor. You turn them all upside down, they all look the same because they derive as a neuroendocrine cell. They also have properties that make them unique, and these are the things that we're hearing more and more about with the different diagnostic tests. For instance, you can do an FDG PET and an MIB, meta-iotobiguanidine test, on these same cells. So they have the ability to be able to be diagnosed by using these 2 different kinds of scans because of the nature of the of their membrane for the VMAT receptor. So you can do an FDG PET on a neuroendocrine tumor, as we learned. You can do the Octria scan because of the membrane for the G protein that receives in a key lock situation to the cell. So you can do a diagnostic on that tumor by using the Octria scan. You can also do what they call F18 DOPA, which is dopamine, and that's a PET scan as well. A lot of people rave about it, but it's nice for ganglioneuroma or pheochromocytomas and paraganglioneuromas, but it's not very good when the cells are tumors of the midgut. Whereas the I-131 can pick up midgut tumors as well, and you can use that for therapy as well. And you can also use the gallium DOTA-TOC or DOTA-TATE scan, which is also an octreotide, it's like Octria scan, and you can bind. Now, not all of these cells can have the same property for diagnosis. So it does matter where they're growing. If they're growing in the thyroid, if they're growing from the adrenal gland, or if they're growing from the midgut or pancreas, they all have an ability to do one or the other in terms of being able to diagnose them. But that's their property. So they can be scanned. They can be seen non-invasively. This is the first of the only 2 slides to show you, but every organ up there has normal neuroendocrine cells. So we heard thyroid can make a tumor. You can have a tumor from the lung, tumor from the stomach, or tumor from the pancreas, tumor from the midgut, and the reproductive tumors are also can be neuroendocrine tumors of the reproductive system. These are cells that have come to reside there normally. Understand these neuroendocrine cells are recognized by other parts of your body. So if a tumor from your midgut goes to the liver, it doesn't chew on your liver. It lives in your liver. And I had a patient 3 weeks ago who had some reduction of his liver. He came in working 150 hours, and instead of 30% liver tumor burden, the estimation by 2 semi-quantitative methods was he had 90% liver tumor burden. His liver function studies were absolutely normal, and the other 10% of his liver was working fine. So it's very important that you know. So if it goes to your bone, you rarely fracture. It lives in your bone. It shouldn't be there. We got to get rid of it, but it doesn't break bone. Pathologic fractures are less than 0.9% of neuroendocrine tumors fracturing a bone. So that's an important concept, as you remember. When they go to other places, they don't kill necessarily. The autoimmune system recognizes your body part, and they don't attack it. And it's exactly those same areas of cells that give you this, the tumors. And now you can see the breakdown. You heard how much the lung looks like the pancreas. It's derived embryologically. And in fact, foregut tumors include pancreas, stomach, and lung. Lung, pancreas, and stomach, first part of the duodenum. The midguts are the ones that start in the jejunum, go down through the ileum, through the appendix cecum, and into a mid-transverse portion of the bowel is all included in the midgut. And the hindgut then includes the rectum and the distal large bowel. Now, that's the distribution of, and those circles that you see there were the number of patients that come in as a tertiary referral center to us. So out of the 1,800 patients that are registered at our university, 55% are midguts, 25% are bronchioles, about 20% are pancreatic neuroendocrine tumors, and then there's the adrenal gland tumors and the medullary thyroid cancer groups. This was Enrico Solci. I mentioned he's still alive. He's a wonderful man. He's from Pavia. He convened the pathologist in the year 2000 at the direction of the World Health Organization, and they said, you come up with a classification for the neuroendocrine cells. The classification is one we're all familiar with in this room. The first 2 are both well-differentiated tumors, and they have a Ki-67 proliferation rate of between 0 and 20%. Grade 1 and grade 2 behave about the same, so you'll always see them put into statistics in the same group. Grade 3 are the poorly differentiated. The small cell neuroendocrine tumors and the large cell neuroendocrine tumors, they have mostly synaptophysin in their tumors. Chromogranin is mostly present in grade 1 and grade 2. But there you see the Ki-67 again, and Ki-67 helps you classify them into grade 1, 2, and 3. What is the Ki-67 exactly, so you know? It's an antibody that's been raised against an antigen in chromosome, it's a single gene, chromosome 10, on chromosome 10, that's tightly associated with cell cycles. It's an excellent predictor of tumor proliferation. Ki-67 is where they found it, I think, in Germany, Kine or Kin. It's a pathology. It was a city that they named the antibody after. But it's been perpetuated, and as long as that antibody can be consistently made, every path lab in the country can do the test. And that is all it is an antibody that looks at the proliferation rate of a tumor. That means 20 years ago, I could take your tumor and assess the proliferation rate of it by measuring this Ki-67 antigen. And it's a histology test that's been around since 1958. And that's a stain, so that's how they do it. They do a stain and then count the black nuclei, and in this case, those little black nuclei represent the Ki-67, and if anything greater than 2% of 1,000 cells is a grade 2 up to 20%. So grade 1 is less than 2% of these proliferation nuclei. 2 to 20% is grade 2. Keep in mind they do them together, and then this is obviously a grade 3. It's much higher than 20% of 1,000 cells. You all have this sheet, and I want you, it's designed to show you a couple of things. So when you're by yourselves in your brightest, your deepest or your happiest moment, you need to look at that sheet and count the TTPs with each one of the therapies. So that's our schema. I want you to notice on that each one of those boxes represent a therapy. And on top of each of them is a time to progression, TTP. That is to say, if you had 100 people with your identical problem who had the identical box, let's say arterial embolization, 50% of them would have an average time to progression. That is, moving from one point to another of an average number of months or years. So a person that has the hepatic arterial embolization has an average time to progression of 3 to 4 years. A person who has debulking surgery or removal of the primary surgery, removal of the primary tumor, even in the face of metastasis, has an average time of 3 to 5 years. So you just add those two boxes up and you see that you're measuring things in years, not days, weeks, or months. The same obtains for PRRT, which is in the lower left corner. I have a predilection for how I think, or a preference for how I think it's going to be in the United States once the PRRT comes as an approved therapy. I think people will be surgerized and then be offered 3 or 4 cycles of PRRT, and then followed some 4 or 5 years later just for checkups, because I think that the PRRT now has finally started to move up the therapeutic ladder most rightly. Up until now, it's people who have had many of these options of care and now are getting the PRRT. So each of those boxes have a TTP, and I'm not going to talk to all, but I will allude to octreotide. I will not allude to the hepatic arterial embolizations. We'll allude to the anti-angiogenics that we've heard already about this morning, and I'll show you a small piece of our work from the PRRT that we did over the last 12 years. Okay, these are the 3 things you need to know on the top is how this is native somatostatin. If you'll see, it's in a ringed formation. There are only 3 ringed peptides in the body. Oxytocin's another one, but if you break that ring, somatostatin action is turned off. So when Sandoz made their modified, this is a modified octreotide, but when they made octreotide, they went from 14 amino acids, 14 proteins that nature gave us, down to 8. For them to make an 8 out of 14 of a natural peptide, and it worked, was the first time that had ever been done. They received the Prix Gallion Award, which is the Nobel Prize of Industry, and they were the first to do it. And then David Coy, this is lanreotide on the right side. And as you can see, they look almost identical in terms of the protein moieties that are on it. And in fact, they are. It takes more lanreotide than octreotide to do the same thing, but you can see that structurally they're the same. No surprises, they do the same thing, they have the same side effects. Lanreotide depot is a very, very good drug because it's a square wave. When you take a shot, the lanreotide level goes up and it stays square wave just like Lantus insulin for 30 days. When you take octreotide LAR, you have a 12-hour peak and then a trough over the next 30 days. So it's a little bit rougher when you take octreotide LAR than when you take lanreotide. So lanreotide gives you a steady, smooth level. That's one of the advantages. It's given deep sub-Q versus IM, which is LAR. So as a deep sub-Q, it's less, as Dr. Wolderine says, tiny heinies, people who have small gluteal muscle can't keep taking LAR forever because they get massive granulomas. They can't even sit sometimes, and that's when depot, a deep sub-Q, works very, very well. But the absorption's identical, so you get 67% absorption with deep sub-Q, lanreotide, or with LAR. So as you can see, you waste a lot of peptide when you take those 2 forms. You're not getting the full 30 milligrams of LAR or the 60 milligrams of depot. It doesn't work that way. You get a certain percent of it, and I think over time the granulomas keep you from getting more for even absorbing that much. But one of the things I just want to point up here, you see the lysine in this position. Here's lysine, that's an amino acid, and here's lysine. Notice nature gave us this lysine there. We mimicked it, and that's where the docking goes on. That part of the key of the peptide locks into receptor subtype 2. It's the lysine moiety. If I took lysine out of there and put another amino acid in there, it wouldn't work. So those are the 2 compounds, but just do appreciate they're the same. People, and I've heard many times, and I've used lanreotide, it gives you a very smooth kind of level, and people prefer that over the octreotide. And this is just, I want to hurry, but I want to just show you something kind of phenomenal. So 2014, we celebrated 25 years of octreotide in the United States. It was approved in 1989 in the United States and approved in Europe in 1988. They were using lanreotide in Europe shortly after that as well. But the approval for the actual use of the drug for secretory diarrhea of carcinoid and for VIP secreting tumors was was done by the FDA. But what I want to share with you is this slide, and this is with permission. This is the actual FDA information that they received. Now, if I was talking to a group of medical oncologists, they would close their eyes because medical oncologists are driven by protocols. They're driven by a group of patients that receive placebo versus another group of patients with a problem taking a drug for effectiveness and FDA approval. The FDA approval of octreotide came from 173 patients from 79 different doctors in Europe and the United States. It was used so fast as a compassionate drug that they couldn't even start to make a design of a study because it was being used and given compassionately for the use of symptomatic carcinoid tumors as well as the other neuroendocrine tumors. And that's the list of the tumors that they studied. That's the list that the FDA holds on file for the original approval. And this is how the data looked. So they made columns and they said improved, unchanged, resolved. So they gave it a score system and then they assigned those categories and then they came up with the, and as you can see, this is the flushing of carcinoid patients. Oops, sorry, just real quick. But the clear bar on the left side are the number of patients that had complete resolution that were improved with the octreotide, and the black is the resolved. So you can see a very large number of these patients had improvement of less than 50% diarrhea, of flushing episodes dropping 50%, or complete abolishment when the octreotide was used. So you can see it's a semi-quantitative way that they got numbers out of this, and that's why it was approved for carcinoid based on those patients and based on that classification. And this is the diarrhea, and again you can see the improved is the clear bars, the black bars are resolved, and the unchanged are small percent. So based on those numbers, they approved it for indication for the diarrhea of carcinoid syndrome. This is the VIP that you hardly hear. Maybe there's one or two folks, or you're aware of somebody with the VIP syndrome, which is called pancreatic cholera. These patients require 8 liters a day, 3 catheters running in their vein to keep up with their diarrhea. It's like pancreatic cholera. And there on the bottom is this one patient who received the sub-Q from the NIH. And you can see all those white bars as the number of stools that the patient had and the complete resolution with 3 injections a day of a very low dose of octreotide. It's one of the most powerful cases that brought the approval in the United States for the use of octreotide for diarrhea of a vipoma. And those are the peptides right there. You can see it just fall off the table. This patient was making multiple neuropeptides, including VIP, neurotensin, pancreatic polypeptide, and motilin. And all of them just shut off with the octreotide. Based on this case from the New England Journal and the studies that they did, the 177 patients, that's what brought the approval. And it hasn't changed since. For 25 years, we've had a drug that works. But it doesn't just work on the diarrhea of carcinoid or VIP. They have 81 different published uses of it. Okay, and this is the PROMID study. I'll work through it very fast. This was the first time octreotide was shown to be against the placebo, and in fact, it was shown to be a mild anti-proliferative. So the anti-proliferative part of sandostatin was in this article in 2010, and this group only used the midguts. As you heard this morning, they used midgut tumors that they treated with octreotide, and they had an anti-proliferation effect. This is the one that's the clarinet study that just came out in the New England Journal. This is with lanreotide, and this was done with a broader group of patients with a higher Ki-67, and now we have an anti-proliferative indication for lanreotide. Octreotide is not approved by FDA as an anti-proliferative, but of course does. So I don't know what they're going to do about that. That's their problem, but clearly lanreotide is for indication as an anti-proliferative. These are the anti-angiogenics that are approved for pancreatic neuroendocrine tumors, everolimus and sunitinib. You've heard a bit from Dr. Hal this morning. And the medullary thyroid cancer has also got 2 anti-angiogenics that work for metastatic disease of the medullary thyroid cancer. And I'm not going to go through that. Here's Theranostics. Theranostics is nothing more than the same key with a cage on the back, and in the cage you put gallium and you get a picture. After you get a picture of the tumors with gallium, you take the gallium out and you put yttrium 90 or lutetium-177, and now you have therapy. The combination is called theranostics, and that's the term for the diagnosis and the therapy of PRRT. There is octreotide. We use the dotatate. The cage is shown right there, and the isotope goes inside the cage. If you use gallium at the bottom, you have a picture. If you take gallium out and you put Y90 in it, you have a therapy. And if you put gallium, if you put lutetium in the cage, you have a therapy. There is no difference in the response between yttrium-90 and lutetium-177. They both have the same average time to progression of between about 28 and 38 months. The average time to progression. That means how long does it take 50 people to progress? 50% of the people to progress on the therapies. Lutetium offers nothing more special than yttrium. Yttrium is a more powerful beta emitter. It travels only 8 millimeters in the body. It never leaves your body, and it only hits the target that it's bound to, and has very little collateral damage to any other structure. Lutetium is the same, except it's a shorter distance. It's a softer radiation. It mimics I-131, but the point is not one is more superior to the other. The side effects, the damage, the organ-limiting damage with yttrium-90 is the kidney, and they protect the kidney. The organ-limiting damage with lutetium is the marrow, and you need to watch the marrow very, very closely, especially with lutetium, because if you lose that battle, you lose the war. There it is again to show you the arrow sticking into the target. And this is a study of our gallium against octreoscan, only one slide. You can see the quality, as was pointed up earlier, with the octreoscan versus the quality of the gallium on the right side. Seeing more lesions is not very satisfying, okay? And it leaves people sometimes very unnerved when they didn't know they had it in their bone, and it's showing up for the first time. But you need to remember that the gallium is the forerunner for the therapy. So most of our patients are with intent to treat, because everything the gallium sees will be targeted by the therapy. This is the outcome study, the only piece I want to show you on the PRRT, but to show you the value of another compound when you do the PRRT. PRRT, as you know, stands for peptide, which is octreotide or even lanreotide. Receptor, which is the SST2, that's the lock, key and lock. Radionuclide is what you use, yttrium-90, gallium, or lutetium therapy, PRRNT, and that's what it stands for. This was a study we did together with Dr. Thor Half-Donnerson, our medical oncology people, and our patients. We had 150 metastatic neuroendocrine tumors, and that's the distribution. 44% were small bowel, 28% were pancreas, and we had the fortune of being able to look at lung metastasis as well. They received PRRT, most from Basel, Switzerland, but some 26% from our institution when we had the yttrium PRRT back in 2000 and 2001. So 86% received yttrium-90 and 13% received a single therapy with the lutetium. And all were followed in our clinics for 10 years forward. They're still being followed. So every patient treated came back on a regular basis, and we watched them and observed them, but we did one thing different. Unlike Europe, we gave them octreotide before and after, and kept them on octreotide after the PRRT was done. And Europe did not do that for 10 years. They used to tell people, you've been treated, you don't need octreotide. Okay? That's where they got their progression. And this is the most important table. So if you look at all sites and you look at the time to progression from the first PRRT, we had 39.6 months, which is the average, that's the max average of the European. But if you look at small bowel tumors that were given octreotide after PRRT, the time to progression was 5 years. That's the average time to progression. And the only thing we did different was give them octreotide before and after their treatment. If you look at PNETs, pancreatics, it's 63 months. That's 5-year average. That's not even, that's beyond, almost 2 years beyond the average with PRRT alone. And all we did was keep them on octreotide. So we're very, very proud of this. And then if you go back and look at the overall survival and you do the numbers and the math, you'll find out that these patients were all treated late in their course of their disease, as everybody has been with the PRRT. And we came up, we, not me, Dr. Thor Halfdonerson, our medical oncologist, made this statement before anybody in Europe made it. That is, PRRT appears to be a valuable treatment option for metastatic NETs, especially small bowel NETs, and its role earlier in the disease course seems warranted. And that's where I believe very strongly that once we start getting the PRRT here, that progress will be made with surgery and then the PRRT. One last caveat, they now have a PRRT which has a broken key. So instead of the key fitting naturally into the receptor lock, it's a little twisted. So when it goes onto the cell, it sticks there. And the antibody is called JR11. You'll be reading about it. It's called, and I think it's DOTA JR11 PRRNT. And it gives you much better labeling and energy close to the tumor. If all goes well, we hope to have that within a year for the diagnostic scan that goes with it, and then eventually try to get this study. It's put out by Octrea Farm in Europe, and it's a remarkable, it's counterintuitive, because how could something stick like a broken key? It doesn't go inside the cell, and yet it gives enormous therapeutic advantage. So that'll be the next thing beyond the standard PRRT. I want to be around for any questions, and let me show you our team of players. We have a great group, and the point I would just make is when you go to a center, the most important person probably outside of your manager is your surgeon. And as you can see, Jim Howe is our surgeon. He's co-director. And nuclear medicine is a very big, powerful advantage that we have at Iowa. They've been very supportive. And we have the medical oncologist, and the wizard in the lower right corner in yellow and in bold is Dr. M. Sue Odoricio. She's a pediatric oncologist who does the kids and who is solely responsible for our INDs and NDA and for our ability to open the Y90, which will go from ages 6 months to 90 years. So it'll be the first protocol in the world with children. I wish you well. Thank you very much. Peace.